March 11th, 2020, the World Health Organization declares the rapidly spreading coronavirus outbreak a pandemic. COVID-19, the disease caused by the virus, has hit the United States and is known to have a particularly devastating impact on citizens with pre-existing conditions and those over the age of 65, with fatality rates up to 10 times that of the common flu. A deadly disease, a vulnerable population over the age of 65, concern is elevated in those regions of the country with the highest density of older Americans. Among the top 10, Vermont, New Hampshire, and Maine, with 19.4, 18.1, and 20.6% of the population over 65, respectively. That's 1 in every 5 citizens at a heightened risk level. So an urgent question emerges. How do you get vital and accurate information to older citizens about prevention? And when that's not enough, healthcare at the local level so that lives are saved, and the healthcare facilities, hospitals, and ICUs are not overwhelmed. The Connecticut River forms a valley where a series of towns from both New Hampshire and Vermont feel a common connection, known by local citizens as the Upper Valley. The Dartmouth-Hitchcock Medical Center is there, and so is an innovative group of people who have formed what is known as the Upper Valley Community Nursing Project. They've been thinking about this question of good health care to older citizens for some time now, and they've come up with innovative solutions. Use a strength-based community approach, building on trusted relationships, embedded in long-standing communal connections. We spoke recently with the co-directors.
I'm Dr. Bob Roosvold from Lyme, New Hampshire. I'm a family physician. I was a family physician in Lyme for many years. And for the past several years now, I've been working with Laurie Harding on a community nursing project in our community.
And here's Laurie to talk about her experience with the project.
My name's Laurie Harding, and I'm a nurse. I've been a nurse for many years and have had a very diverse nursing profession over the years. But over the last 10 to 20 years, I've spent a lot of time working with the VNA, the Visiting Nurses Association, in the area of home care. And I've done many jobs for one particular agency. And then I've had the opportunity also to be a consultant for a non-medical home care company. But throughout that time, I've really had the opportunity to observe how many people there are in the community that really don't have an opportunity to have the care that they need, in part because the system doesn't allow for it based on the requirements that we have for care at home.
I asked Laurie to describe to us what the history was of the Upper Valley Community Nursing Project.
My original connection with this program was through a geriatrician whose name was Dennis McCullough. And at the time, Dennis was the medical director, or had just finished up being the medical director, at a continuing care retirement community in the Upper Valley called Kendall. And Dennis and I used to get together for coffee. At that time, I was working for the Visiting Nurses. And we would have long conversations about our concern about the health and well-being of older adults, because we saw what was happening to the demographics in northern New England, and that our 3 states were fast becoming the oldest states in the country. And we were concerned enough so that we started wondering if there was anything that we could do. Were there any programs that we might be able to design and implement that might help? And at that time, Dennis McCullough had just finished a book called Your Mother, My Mother. And it was really a book supporting older adults aging in community and supporting their families in the wisdom of his own experience and his ability to share that. And he started to do some speaking around the Upper Valley, and a couple of times I went along with him. And it became apparent that the people that had asked him to come and speak had started aging in community programs, Aging in Heartland, at home in Norwich, the Thetford Elder Network. And these programs had wonderful volunteer initiatives, but the volunteers were feeling that they didn't have the skill and the expertise to deal with some of the medical issues that some of the older adults in their communities had. They didn't know how to get somebody who had a hip replacement in and out of a car, and they didn't know how to answer questions about medications, nor could they talk to people about the difference between hospice and home care. And so they started asking Dennis and myself when we would go and speak at their communities, can't you help us get a nurse? And that was really how this program was started. And it was also based on the fact that the Upper Valley had 3 parish nurses at the time. And we looked at their job descriptions and started meeting with them and started thinking, well, what an incredible service these nurses do to their congregations. I wonder if we could do something similar for the communities. So that was really the beginning when we went back to the communities and spoke to them about this design, and we're very clear that this had to be a grassroots initiative, and the communities really needed to be able to hire their own nurse, but we would help the communities design a program and develop job descriptions and help them with a model that might work for them. So we would be the coaches for the community. But that's really how it all began. It really began because the community in this area were really committed to helping people age in community, because they wanted to or because they had to, because they had no other option. So they were the ones that really pushed for a nurse. And we went from the 3 parish nurses, who then became 2 parish nurses, to now 10 nurses that are serving the Upper Valley in different communities.
So these are critical roles that are filling a gap, it sounds like, in the community. Community nurses are responding to, are these new needs of the community, or do you find them just unique to the Upper Valley?
Well, I'd like to respond as a community-based physician, as a family physician. I've recognized that over the years, a physician in their clinic and their office is somewhat limited, and even a physician as I did that does house calls is still somewhat limited. Doesn't always have the eyes and the ears on the community, and more we recognize that there are what we call social determinants of health, social needs that people have. And that may be income, it may be the abilities to drive, it may be the abilities to get meals. There are a lot of things that affect people's health, oftentimes much more significantly than just their day-to-day medical needs. You know, we can give a good medication and get blood pressure under control, but there may be other things that are impacting their health and affecting their blood pressure. So that's one thing, is that oftentimes medicine at even the primary care levels all the way to the tertiary care, the hospital level of care, doesn't address what's going on socially in communities. And of course, in many communities, that we recognize that there are great disparities, oftentimes inequities in healthcare, so that communities where there are large numbers of people of color or older people, oftentimes their needs aren't being met because we have a somewhat inequitable system. And the only other thing that we see is that, and I think Laurie may have mentioned this, is that oftentimes our healthcare system is based upon a system of what kinds of services can be reimbursed. If a person is referred to a visiting nurse out in the community, as an example, after a hospitalization, maybe they've had surgery and they have some what are deemed skilled nursing needs, where they maybe have dressing changes, wound care, follow-up physical therapy after a surgery. Those are skilled needs that are deemed appropriate for reimbursement for a period of time by Medicare. But if people don't have that set of circumstances, then they may have still very important medical issues, health issues, psychosocial issues that aren't addressed, aren't reimbursable, and they're discharged from visiting nurse, or they're never eligible for visiting nurse care. So our community nurses, their services are really based upon need, not what's reimbursable, but really based upon their healthcare needs, their social needs as well. We don't separate those out. So those are the things that a nurse out in the community is often doing. She's just not going in and checking blood pressures. She's going in and finding out what other issues might be limiting that person's ability to stay in their home, to age well in their community. That might be doing some simple things like making sure their house is safe, that there aren't risks for falls in their house that suddenly put them in the hospital with a broken hip. There's all kinds of things like that a nurse in a community parish nursing role will take.
Interesting. And so, Laurie, in the context of our current situation where our medical services are stretched thin dealing with a pandemic, how do you see the Upper Valley Community Nursing Project stepping up to the plate and responding to our current crisis?
Well, we've gotten very interesting feedback so far, Roy, from our community nurses, and they all have a caseload, and together right now, the nurses are taking care of about 225 people in the Upper Valley. And over the lifetime of the program, since we've had the ability to collect data, which is really only about 5 years, the nurses have taken care of over 500 people. But right now, their role really has changed because all of a sudden, the frail older adults that they're taking care of are increasingly isolated, don't have a great understanding of what it really means to be socially distanced, and they're having increasing numbers of questions from other members of the community about the pandemic. So their role has become that of an infectious disease prevention professional to some degree, and that they're spending a lot of time really helping people understand and digest the significance of this pandemic. A lot of their clients who were able to get out of the house might have gone down to Lebanon to the co-op every day. It was part of their routine, and to get people to change their routine and to understand that the best and safest way to get groceries would be to have somebody else do it for you or only go down once or twice a month. Very difficult when people have a certain pattern of daily routines that they've adhered to for a long time. They're also really working hard to make sure that people understand that when people come into their home, social distance needs to be respected, and people really need to be very careful about infection control. For example, careful hand washing and the use of hand sanitizer is really critical in making sure that people who go into older adults' homes might at least keep their distance respectfully, and also make sure that they don't leave any evidence of virus if they themselves might have the virus and not be symptomatic on people's coffee tables, on their sinks, on their coffee cups. And that's been a big challenge for the nurses. I don't think they ever expected to spend so much time in really trying to talk through the necessity of these prevention practices that we all need to utilize right now. And at the same time, they're still trying to maintain their relationship with a group of clients that have got multiple chronic diseases, who've got a significant amount of depression from being socially isolated, whose families are on the other side of the country. And they're very dependent on the fact that the nurse is there to be a care manager and also to help them be able to access the primary care providers who are not as accessible as they had been before. There are a lot of telephone triage lines that are set up and telehealth systems set up. And sometimes that may or may not work for older adults. To begin with, a lot of people are not able to hear effectively. And so even if they talk on the phone to have a telehealth interview with a PCP, people aren't able to understand sometimes what the doctor is telling them. So the role has changed significantly, but it's really clear to me, and I think to Bob also, that these nurses are really going to provide a safety net for a lot of people in the community. And people more and more are making themselves known and reaching out to the community nurse. They know that that nurse is there, and they recognize that they trust the nurses. Nurses, almost 100% of the nurses are from their own community, and so they know some of these folks already, and they have a lot of respect from the community, so people feel very comfortable reaching out to them.
Let me add to that just briefly. What also is important is the recognition that we have that this virus that's going around, and of course, it's pandemic, it's sweeping the world. We're seeing what's happening amongst older populations and in countries like Italy, Spain, France, Germany, etc. Those people that we've been working with in communities, the older folks in the communities, oftentimes, as Laurie said, with multiple medical problems, perhaps diabetes, some heart problems, maybe some chronic respiratory problems, they are the targets for this virus. This virus doesn't treat them well at all. Somebody who's 25 years old, they're not immune from this virus, and they're not they're not immune from serious disease, but they're much less likely to get serious disease. But our older folks are the ones who are most affected. The rates of serious viral infection and the rates of hospitalization are extremely high once you start getting over 60, 65, 70. Virtually almost everyone over age 80, the hospitalization rate and the rate of severe complications is extremely high. So we felt it was urgent within our communities to try to respond to what the nurses have been saying to us about their changing role and what they're observing. And our first thought was, we have an obligation to try to scale up, to try to kind of surge our capacity to respond to other towns around New England, around Vermont and New Hampshire. And perhaps in so doing, we can also provide a model for other regions and other communities to quickly get skilled community nurses up and running with the focus on how to address at the community level this COVID-19 virus, the COVID virus that's going around. One other observation that's important for people to know is that we're just beginning to see the beginnings of it. As Dr. Fauci and others are pointing out now, over the next 4 to 6 to 8 weeks, the worst is yet to come. And in New England, we've had a little bit of a gap in time. Our numbers are increasing, but it's just a matter of time before those people that have the virus out in the community, that are interacting with others, those numbers are going to climb, the hospitalizations in our region are going to climb, and the amount of serious illness and death in our region is going to climb. But we've had a little bit of a window of opportunity to see what's happening in other communities and to say we really need to look at taking some action now. This is an opportunity for all of our communities to really hunker down, practice the safe interactions, social distancing, or some would prefer to call it physical distancing, because we're not saying people should not socialize. It just will be better to socialize over the phone and over FaceTime and Skype and such. When we have people that are getting the virus, and a large percentage of our community could very well get the virus, those people who are seriously ill represents about 20% of the people who get the illness from the virus. And that 20% most likely will be hospitalized. Some will need ICUs. There's a very high proportion will need ICUs and support of their respiration. But 80% of people with this virus could still be quite sick. It could still be out there in the community, both at risk for themselves and for their community, their families. And 80% are not cared for in the hospitals, the tertiary facilities. So really the front line where most people are going to get their care is out in the communities, and we're just not geared up for it. The primary care practices, just the physician offices out in the communities, they can't manage it. The visiting nurses can't manage it. So our thought was, let's see if we can kick it up a step to see what we can do by getting more community nurses on board and try to expand the effort to support our communities in the community-based, what's called mitigation efforts to try to lower the rate of spread of this illness.
Absolutely. And the community nurses are also working very closely with the first responders and the teams that have already started to spring up in all of the small rural communities. So they're an integral part of a system that has been put together locally. So they really have two focuses, really that of ongoing education around COVID-19, as well as keeping a careful eye on their current population of clients who, as Bob said, are at great risk. I think the other really important thing to recognize is that we as healthcare providers have a real obligation to try and keep these people out of the healthcare system right now, out of the hospital, that is, out of the emergency room. It's one thing if they can connect with their PCPs, but in order for them to really stay out of their hospital, we all need to do our best to try and keep them well as can be expected in their homes, in their apartments, so that they can not create more problems. The last thing the healthcare system needs right now is a lot of people in the emergency room, because there have been complications of their chronic diseases, or they've fallen, or they have problems with their medications.
Many of the frontline health facilities have been the family practices, the pediatricians, the small town internal medicine docs, and so forth. And many of those have had to curtail routine care. They've suspended regular clinics. They don't have a way to safely get people in and out who might have respiratory disease, have the COVID virus. So they're going to telephone and other telehealth types of exchange. But the routine care that they provided to large areas of our communities has just sort of not there in the same way. They're responding as best they can, but they're responding primarily to the overwhelming need that's coming out of dealing with the virus. So we want to be absolutely sure that a lot of people in our communities don't sort of fall between the cracks, and that there is some community-based surveillance out there. A skilled community nurse will really keep a good eye on those folks and help to, again, I think that's where the battle for this over this virus is going to be won. It's going to be out in the communities.
Well, Laurie and Bob, the way you describe it, the Upper Valley Community Nursing Project is really filling a critical need right now, and support is urgent. Can you tell us a little bit about how we could support the project and what you see as the next steps?
Sure. We just sort of woke up a week or so ago after, hearing reports from our nurses and realized, as I said earlier, we realized we have an obligation to try to do more. And when Laurie and I first started sitting down talking about this, I tried to inject a sense that I have of urgency, because I've worked in public health settings in the past. I've done a lot of work over in Africa. I have been involved with some epidemics in the past, some cholera. I was involved not in country, but involved with Ebola. So I know what can happen in communities where massive epidemics come sweeping through. And I saw this as somewhat urgent, that we can hopefully get ahead of the curve, if you will, get things going in a way that isn't just business as usual. By that, I mean, if we go into a community, let's say in the Upper Valley, I live in Lyme, we have nurses in Lyme and Thetford. If we were going into a community brand new, we would work with people in the town, with a committee of people interested in getting a community nurse on board, perhaps with leaders in the town. We would be in a process probably for no less than 6 months. We have one town that's just come on board with a new nurse they've just hired, and it was about a year's process to get a nurse on board. So we're really looking at the need at this point to say this is not business as usual. We need to get hired community nurses that could be, volunteer or part-time paid community nurses, perhaps coming out of retirement for a 3 to 4 month to 6 month commitment, and to get those nurses out into the community. So our goal now is to get 10 new towns in Vermont and 10 new towns in New Hampshire up and running fairly quickly in the next few weeks. And so we're in the process of mounting support for that from within our region, within leaders in the communities, partnering with emergency task forces or committees within towns, looking for funding that will help us mount this effort, because we really don't have the resources to do it. So we're going to be looking for some of the federal funds that are coming into our states to help us fight this virus. That's kind of where we are right now. Laurie, you might add to that.
Well, I think that we've known for a while that we have a good model. We've had a lot of interest in the model, but Bob is right in saying that one of the features of the model that makes it unique is that it really is built from the ground up, based on a small group of community volunteers who are looking around at what's going on with people in their own communities who are concerned about their friends and their family members, their neighbors who have lived in their community for years and really are committed to trying to support their desire to stay in their community. But it does take a long time. One of the communities that just brought the nurse on started off with focus groups and surveys, and spoke with the police and spoke with the town fathers, and really worked their way through this process. And they were volunteers. They had a couple of nurses who were active in practice and a couple of other individuals who worked, and they just met once a month for the first 7, 8, 9 months, and then got to a point where they applied for nonprofit status, which is where they are right now, and worked with a local church to become their fiscal sponsor initially, or at least have their initial bank account in their budget. And then have agreed now to move on to hire the nurse as a small business. And they've just done that successfully. And they are so pleased with the end result. But as Bob said, it's a long process, and all the communities that we have on board right now have all gone through that very slow, thoughtful process and have engaged people and gotten them committed. And that's how they've ultimately been able to fund their programs, because yes, they look for charitable donations, and some of them have written grants. But little by little, the towns have come to agreement that this is a critical program for the town. And they've started putting a certain amount of money into the budget that comes before the town at town meeting every year. And that's been a real accomplishment. But it takes usually a year or two until the town starts to feel that the nurse is really woven into the fabric of the community. We don't have that time now. We really need to move ahead as quickly as we can.
Yeah, I was just going to add to that when we sat down with our Upper Valley Community Nursing Project board and presented this to them, after some thoughtful deliberations that Laurie and I had and a few others, the best way to present it was, yes, there's a lot of very nice things that one would do to get a nursing project up and running in a community. However, this is a situation where it's what I call your house is on fire. There's smoke coming out of the roof, and you need to act now. So we're at that point that we're essentially calling out the fire department and trying to decide if it's a 2-alarm or 5-alarm fire, and getting the resources in to manage it, because it's here, it's in our community, and it is, unfortunately, it is going to be stepping up in the coming week after this is over. And we will get through this. We will get through this pandemic, and we'll hopefully get most of our citizens through it. Not everyone will make it, but we'll get past it. And when we do, then we'll have an opportunity where we mounted these community nursing efforts. We'll have an opportunity to step back and to look at then, is this town, do they want to continue a community nurse? Are they providing some of the community care that we did before the emergency and so forth with other towns? We'll have a lot of opportunity to take the next steps and grow their programs in their own communities at that time. But probably for the next 6 to 12 months, I think we're looking at mounting all efforts to address this emergency.
Well, those who are listening to this conversation may want to show their support in some way by contacting the Upper Valley Community Nursing Project. Laurie, do you have information that you could share with us on how they could do that?
Yes, they're certainly welcome to contact me. People can always go to our website, www.uvcnp.org, the Upper Valley Community Nursing Project, uvcnp.org, and they can see a better description, more of a description about the project. They can also take a look at numerous questions that have been asked by communities and see some of the responses that we had, and they can also see who the current community nurses are in New Hampshire and Vermont, which may be helpful. And there's also a way to contact us on that website as well. And we'd be happy to talk to people. And certainly people don't need to think in terms of a community nurse needing to pop up from their community right away. They are more than welcome to consult with us, and we can easily introduce them to other communities who have started the program and have taken the longer road. But we are really hoping that we might get some funding to support community efforts. And we already know about 67 communities in Vermont that if we could present them with a certain amount of money to help support their efforts, they would start this program tomorrow using the same model that we have right now. And the communities recognize what's coming down the road and the horror of where we're going in the next month to 2 months in both New Hampshire and Vermont. And I think they really understand that some people are going to be left behind because they are going to have a hard time fitting into the healthcare system the way the healthcare system is structured right now. They don't qualify for VNA care right now because they're not homebound or don't have that skill that Bob was referring to. And those individuals will be isolated in their community. And there are also the whole other issue of the education that has to be done for this current pandemic. But as Bob reminded me, we're looking at potentially another round of COVID-19 in the fall. Once it cools off, that virus is not going to just disappear from our communities. We need to practice good infection control practices now, but we're going to have to do it for a long time.
Probably for, the next year. We're going to peak here in a few weeks in New England. The peaks of where this virus is going to be different in different places, and they'll be peaking in New York and Boston sooner. But as it gets further north in New England here, our peaks will be a little later, and hopefully we will have blunted it in terms of the overall numbers. So we not necessarily decreasing the total number of people who will get it eventually, but we're pushing it down so we don't overwhelm the acute medical facilities and the acute care. But then it's going to quiet down. It's going to die down. But as oftentimes the seasonal flus do, it's very likely to flare back up again in the fall, and we'll have another round where we have to do some similar efforts to try to contain the virus and or mitigate some of its effects. There is a possibility that there would be another wave coming in 2021, but hopefully in 12 to 18 months, we start to have some antiviral medications that will make it a less serious illness for a lot of people. And we hopefully in 12 to 18 months would have some signs that we have a good vaccine coming along the way.
Well, it seems that the Upper Valley Community Nursing Project really brings some hope. It's kind of a light in these dark times. An opportunity to take some positive action where you're leveraging strengths of the community, creating a needed infrastructure, and making our community stronger. So thanks for the conversation, Laurie and Bob. I'm wondering if you have any final comments before we leave?
I would pass on, actually, the well wishes from another community I work with. I have a program I work with a community in Liberia, in Colahoun, Liberia, where I spent a year. And so for the last 10 or so years since then, I've stayed in touch and been working with that community. And they know what's going on. They have heard about what's happening all over the world, and they've heard about what's happening here in the United States. And they pass on their well wishes. And they're not going to be immune to it either or from it. They've had a number of cases, and that's going to grow. Probably as our epidemic is dying down in the northern hemisphere, then the southern hemisphere over the ensuing months is going to pick up. And we have an opportunity. This is why I've been so alarmed at what's going on. We have an opportunity to approach it as they ultimately had to do during Ebola, and to try to stem the spread of the disease and the numbers of people infected and dying from Ebola over 2 years through their community-based efforts. So one of the things I bring as a message is that there's lots that we can learn from about how communities have dealt with other epidemics in the past, including Ebola. That should be a prime example for us, even though the virus is a little bit different and some of the preventions are a little bit different. There are a lot of similarities.
Thanks, Bob. And Laurie, thanks for your time. Do you have any final words for us?
I think I'd like to give a shout out, Roy, to our healthcare colleagues and their courage and commitment in this environment, and also especially to our community nurses. They're a unique group of professionals in terms of the gifts that they can bring to the community, in terms of their clinical expertise, their compassion, and their passion, and also the recognition that it's really a lot more about the social determinants of health that Bob mentioned in terms of people's health outcomes. And they realize that as they get to know these families, get to know the individual clients, and get to fully understand the situation people live in and have to control their chronic illnesses in. So I think it's a remarkable time that we're in, and there are a lot of heroes and heroines as we move through this COVID cycle, and we all need to pitch in. And this is the way that the community nurses can really help the situation. It's becoming more engaged and helping to develop more programs around the region.
Well, the Upper Valley Community Nursing Project is certainly something that we all need to rally around. Really appreciate your time, Bob and Laurie, and thank you for your wonderful work in the Upper Valley.
Thank you very much.
Thank you very much, Roy. We appreciate the time to talk with you.
This has been a media production of First Person Services. Visit us at firstpersonservices.com. I'm Roy Gerstenberger.